Okay.
Okay, doctors, over to you guys. Thank you so much for joining us, and thank you for leading this session.
Not at all. Thank you everyone for logging in and joining us, and thank you Ellie and the rest of the team at Southampton for setting this all up. There's a group of us who will probably be taking it in turns to lead these. Mike is a paediatrician, I'm an oncologist, so we're kind of not directly in the firing line in A&E or ITU, but clearly both getting increasing experience with COVID-19, and are happy to either do a Q&A or do a brief introduction, but maybe start with any questions if anyone has any.
If there are any questions, please unmute yourself and go for it one at a time.
I have a question. It's about masks that people are wandering around the streets with or not. Can you just give us sort of, are there any use? Are they one-off uses? I'm maybe behind the curve on this stuff, but I see a lot of people, I'm living in Hendon at the moment, passing by pretty close with each other, and people in staff in shops, and they are not wearing masks. And I think, wow, you know, maybe they're useless. Can you enlighten us?
Oh, again. Hi, Aubrey, can you hear me? Can you hear me, Aubrey?
He's muted, yeah, he's muted.
Yeah, okay, so good question. That's very much a frequently asked question. Overall, the bottom line is the way that they are generally being used is almost certainly completely ineffective. So a plain surgical mask is effective up to a point for a very short time. If you've been wearing it for more than 30 minutes or so, it will have become wet because of your breath, and as soon as it's wet, it's completely ineffective. There are higher grades of masks, the sort of masks that are used in hospital by healthcare workers, and you see some of those as well that look obviously more sophisticated, and those are mostly, if you look at the way people are wearing them in the street, also ineffective, because unless they're very tightly and correctly fitted, they are not effective either. It doesn't need to leak very much, and you pretty much might as well not have it. I suppose the non-specific effect of people wearing masks will tend to distance them from each other a bit and remind them perhaps not to touch their faces, and might be non-specifically effective somewhat in that way. But I think in general there is next to no evidence that they are, in the way that almost everybody is using them, if they're using them at all, that it's a waste of time.
I'll just add, because you'll probably all read about stuff about doctors and hospitals being very upset about the kind of masks that are being provided, and there are very definite guidelines that may put forward by Public Health England as to what should be being worn. And on the basis of that, the different kinds of procedures that are done in hospital require different levels of what's called PPE, which is personal protective equipment. And in terms of the hospital stuff about doctors being adequately protected, again, most people are only using those surgical masks. So they are thought to give, again, some, like Mike was saying, some reminder in the very short term. So even if you go in to see a patient who's COVID positive, we are needing to wear them. But if you're doing any certain procedures where you're at high risk with what's called an aerosolizing procedure, so anything that's going to generate droplets, then you have to wear the full-on mask, which has to be fitted. You can't just sort of plonk one on and go in the room. It's a very, very tightly fitting mask. So like Mike was saying, they do provide some reminder about the fact that you want to distance yourself, but it's not a hugely effective thing. And actually the main thing is distancing and lack of contact.
Thank you. I mean, so this type of thing, even if it's not preventing you from getting it, are you stopping yourself from spreading it to anyone else by using this, blowing
Well,
outwards?
again, in the very short term, if you've had it on for more than about 30 minutes, no.
Are there any other questions from anyone?
Hi, I've hardly been out in the last sort of 2 weeks, and I'm sort of scared of going out, but should I sort of force myself to take a walk every day?
So Lenny, I definitely would say yes to that. I think there are going to be potentially some very long-term effects of isolating people physically and psychologically. I think the government's advice, as far as I can see, and who knows what the future holds, but seems very pragmatic and very sensible, and that we're not prevented from going for walks or going outside. And I think that is with in mind the very, very important long-term psychological and physical effects of being in isolation. And that is everyone. That's not just people who are under 70 with no diabetes or asthma or anything. Everyone should be, I think, getting exercise. And I think there's a limit to what we can do electronically. I mean, it's fantastic and people can do exercise in the house, but going out for a walk, obviously with all these isolating measures in place, so 2 meters, not being with anyone from your household, that all has to still stand. But I think that people should actually be going out for walks and be encouraged to do so. And also just seeing people on the street, on the other side of the road, those sorts of things have other massive benefits as well.
Right, thank you.
Hi, thank you very much, Mike and Nicola. Just had a question about boosting immunity at this time. Lots being circulated about vitamins and immunity boosting foods. Is that all a complete waste of time given this virus?
Almost certainly it is a waste of time. There's been, I mean, it's the same as about protecting yourself against the common cold. And there's been, over the years, all sorts of chatter about that and very little that is substantiated. And I think this coronavirus is no different in that regard. So almost certainly beyond what is otherwise good common sense, there's no specific evidence for any of that.
And the other thing is just to be mindful of people selling stuff on the internet. I mean, I've had experience of someone selling something which I think poisons someone. So things that aren't regulated and aren't licensed properly and don't go through the normal sort of quality, very strict quality control things, I would avoid massively. I think they can sometimes do more harm.
Nicola, we can only see half your face.
Oh,
we can, now we can't see any of it. Can you move in a little bit to share with Mike? We're just the two of you come closer together. Oh, it's not the 2 meters. It's not the 2 meters, is it?
There you go. Is that better?
That's much better. Thank you.
Yeah, but we can see all of Mike's face.
Yeah.
Good.
That's the important thing, of course.
Can I just follow on from Charlotte's question? Is it not the case that if a person's feeling healthier, their body's in a better state, they're less likely, if they're not as run down, they're less likely to pick up things that are going around? Obviously, corona is potent and particularly contagious, but in general life, you refer to colds and flu. If one's in a better state, surely they're more likely to feel robust against the things that they're breathing in and engaging with out there. Is that not medically proven?
I think what is described as feeling in a better state doesn't necessarily correlate with being in a better state. So I think the normal advice really still stands. So to try as much as one can to eat a healthy, balanced diet. I would never recommend taking additional, you can take multivitamins, but I wouldn't do anything high dose. The best is to try and get things through your food. So vitamin C, vitamin D, well, vitamin D you need to supplement, but going overboard with any of these, there's very difficult to get good data as to whether any dietary anything that you add to your diet is of benefit. And the reason is that what you want to do is to get what's called a randomized trial. So you get half the people to take it and half the people not to take it, and then see which group do better. But the problem with dietary stuff is that you can't control people's diets. You might be able to do a study with, you know, mice in a laboratory, but that doesn't translate into human reality. And because you cannot ever do a trial that's like that, the data is very difficult to get in a normal kind of scientific way. But any data that there is generally shows that high doses of things are bad, and the sort of normal advice of a healthy and balanced range of diets and foods is the good thing to do. And I think, especially when people are feeling very vulnerable, that some companies may prey on that, and people are online and all of that. And I think people have to be really careful not to do anything that hasn't got good evidence behind it.
I think it's a big problem that in the eye of a storm, as obviously the World Health System is at the moment, it is very difficult to acquire knowledge about what to do, because everything is based on anecdote and very small amounts of evidence, and the sort of processes that would lead anyone to have confidence in anything specific just are not possible in an environment like we have. So I think common sense rules for sure, that, you know, the key thing of the most vulnerable people being extra circumspect about mixing with other people and really not doing it at all, and all the rest of us doing whatever we're doing with the maximum sense, and to do things that have a good reason for them. So a bit like Lenny's question, that, you know, the non-specific effect of taking a walk around the block, if you haven't done it for several days, is considerable. And if you're doing it in the sensible way, you will be incurring no additional risk if you make sure you're distanced from any other people, and you're not handling things and you're not touching things.
There's also one other thing, just going back to Charlotte's question, is that obviously within all this sort of tragic kind of situation that we're all living in, there is some good coming out of it. And I think certainly people are trying to do whatever research they possibly can. So there are lots of clinical trials going on. So people who are in hospital with COVID-19, who are unwell, the data is being done in a very sort of collected, very collaboratively, internationally. And there are groups who are really working on finding out whether any of the things that people think may or may not work. Some people think that maybe drugs that are used for malaria, or drugs that are used for HIV, or various other things, may have some antiviral effect for COVID-19. And what I would say again with this, I know people are going to, I've met actually a doctor who is going to buy some of these drugs. They're all done, the clinical trials are done with a lot of care and thought and effort. And I think that, you know, in a way, seeing what good can come out of this situation, you can see with this. So the data's coming out very quickly. All the things like the ethics and all the considerations that normally take quite a long time for a trial to be set up are all being done very, very quickly and very effectively. And for example, at the Excel Centre, what's called Nightingale Hospital, which will be coming in Excel. I know from the oncology side, we're going to be collecting lots of data to see how people are doing, and actually with the different treatments, you know, with what effect does COVID have on the different tumours, and also what the effects of the treatments and all of that. So people are working really, really hard to get whatever good, useful information. And I think that will, in some point, translate into knowing a bit more about what things in terms of lifestyle, or what things in terms of the different drugs and medications will be helpful.
I mean, where we have got to is quite a significant, and this is internationally, I think there doesn't seem to be any differences between the sort of clinical experience of medics in China or South Korea or Iran or Europe or the United States now, as very much clearly developing a very fast moving problem. That we can see who is clearly at more risk, and also how their medical course tends to run, what somebody with severe infection looks like. But we're away from understanding what, if anything, specifically could prevent, or what, if anything, specifically could treat somebody with the infection. For example, it might make pretty good common sense that if somebody's got severe respiratory infection, severe pneumonia, and you know he's got COVID, is it beneficial to give him antibiotics on the basis that he might also have a treatable component to his infection that antibiotics might help with? But we don't know that that's the case, even though it's quite widely done as being, well, you at that point maybe you haven't got much to lose and maybe you've got something to gain, so go for it anyway. But that's different from saying all patients should have that approach, because we just don't know. I mean, I think we do also very clearly know that young lungs seem to be far less subject to severe effects from this infection than, there's almost a straight line through age. And that actually even includes kids with underlying conditions. So far, there's extremely little evidence. There are odd cases all over, including in the UK, but there isn't any clear sign that this is likely at any point to be a problem in the young. I think it's pretty clear that it's not. That was part of the question about school, how long should schools remain open, and that debate that swirled around for a while before it came down, probably just that it's non-specifically helpful if you want to distance people, that schools are an environment where parents will be together to some extent, and the teaching staff and all the rest of it, that's a forum where people are meeting. But no clear evidence, in fact, strong suggestion that really kids are not a big reservoir of the infection, unlike, let's say, standard seasonal influenza, where I think it's very clear that small children, even if they're not particularly ill, are very good at passing it around.
The other thing just to think about is, at some point, hopefully we're all going to come out of isolation, and then what to do then. I'm sure there'll be guidelines and guidance of how to, what to do. But the idea of a herd immunity is something that's been around for a long time, and it's how vaccines work. So, for example, if you give a vaccine to many people, but not 100% of the population, as long as about 80% of the population have had the vaccine and have got antibodies, then that's what's called herd immunity. And that is enough potentially to wipe out whatever disease it is. So the reason that, for example, in Israel, there's been a resurgence of measles is because the percentage of people who didn't have MMR dropped to below that. And then the virus has a chance to kind of reactivate. Now, the question is what's going to happen when we are all coming out. And I think, again, the British government, the government here's advice, which maybe, and I don't know, but maybe was to allow people to mingle a bit and to try and maybe allow the virus to spread a bit, so there is some immunity within, the population. I think that sounded quite sensible, to, not to put everyone into lockdown straight away. It sort of worried me. I feel quite worried about countries that went into early lockdown, because what's going to happen when everyone comes out, because the virus will not have disappeared altogether. And that's why people talk about the second wave of things. But I think, again, then there's going to be, people will need to be following the guidelines very clearly. But, people having this low level of infection, whilst it's all awful when people are infected and they're unwell for a few days, as long as it doesn't progress to anything worse, it's probably not necessarily a bad thing. But again, we don't know how coronaviruses will change, because we know that the common cold is a type of coronavirus, and we know that you can get the common cold repeatedly. So will this kind of coronavirus change a little bit so you can kind of have it repeatedly or not? And we just don't know those sorts of questions. So I think, again, thinking about how we're going to mingle with each other, how we're going to, schools, whatever it is, parties, anything, how we're going to behave differently in the future is something we need to sort of start thinking about. Because hopefully at some point soon-ish we'll come out of isolation.
There was some evidence in the on analysis of the figures from the 1918, 1919 so-called Spanish flu, which is the sort of granddaddy of the world example, of the world experience, was that cities that adopted a very proactive stay-at-home isolation policy overall had much lower mortality than places that allowed a dramatic spike in infections and then a rapid disappearance of the virus. Although they had a shorter period where people were getting ill and dying, many more died overall. It's quite interesting that different areas of the US had very different approaches, from the extreme of lock everybody down as soon as you had a sense there was something going on, to not having a very fatalistic attitude. And I'm sure individuals must have taken all sorts of different actions, but the authorities didn't encourage it. But although they got rid of the disease quite quickly because the population were much more quickly exposed, they lost many, many more people than the places that did more of what the kind of thing that's going on around the world. Broadly speaking, we're all doing the same, in a way, following the lead of China, that's adopted very draconian measures, particularly in certain areas. But it's a sort of living experiment.
Can I ask a question about what getting back to regular hospital treatment will be like? How are hospitals going to be cleaned and fumigated so that they are safer? I can never say hospitals are safe, but safer places for regular patients to be treated. How will sick people be normalized, the treatment of sick people be normalized again?
So I think, Lydia, I think, historically the rate of hospital-acquired infections has been, we're aware of them, and we know that they do happen, whether it's pneumonias or something like C. diff from the drugs that we give, or MRSA. And a lot of measures have been put into place in the last few years, particularly for things like MRSA. And I think people are very, very aware of those sorts of infections. I think generally hospitals have become cleaner. If you go onto any ward in most hospitals, there'll be a board to say how many days it's been since the last C. diff infection or the last MRSA infection. I think this is a completely different beast, and I don't think you can, the short answer is I don't know, but I think we may be working differently. Our working practices are already completely different. We're doing much less face-to-face consultation. So almost all of our work now is by phone, even when you need to consent people for significant treatments like radiation or chemotherapy. We're doing it all by phone, but you do have to lay eyes on someone. You often have to examine people. So we can't do it all, and I don't know whether we'll go back, everyone will just slip back into sitting cheek by jowl in your office and all of that. I think some of that will have to resume, because we can't work like this for forever. And hopefully, if this virus doesn't, goes away, just like the influenza pandemic settle down, the questions will be, well, do we go back to what we were doing, which was sort of okay, but not brilliant? Or do we learn, and I'm sure lessons will be learned from this. I'm sure we'll change our working lives, and hopefully the amount we fly around the world, all those sorts of things. But certainly in terms of cleaning after, for example, COVID, we're using ultraviolet light. So if there's a patient today who's in a room who's almost certainly got COVID-19, you have to put a UV light in the room. So there are very specific things that we do for COVID that we would, and then deep clean the room, which you just cannot do every day for every patient, because you wouldn't get any work done. So there are specific measures which will stop, but hopefully we will kind of learn lessons from it and change other things.
Thank you.
I mean, of course, on that note, the sort of can, if you like, of healthcare problems for most other problems has been completely kicked down the road in every healthcare system, because everyone is there's really only one sort of threat in town that is being dealt with. So whether all the other problems, which of course were all that took up all of our time all over the world, unless they're extremely urgent, are being pushed to one side, and that is going to have some adverse consequences for some of those individuals. I don't think that is difficult to argue, but there's so many things have changed. Like, for example, if you did too much diagnosis without actually seeing a patient in any other time, you would be considered negligent. You've prescribed and you haven't even seen the guy. You can imagine the sort of response you would get if you turned out to be wrong. And so many of those things have been suspended. It's really an amazing new world that we're living in.
But again, going back to what I was saying, you know, some of those people are going to look at the outcomes and say, well, was all our intervention good? Because we know that there was an Israeli doctors' strike and the mortality went down when they were on strike. So, you know, it might be that some of our intervention is not for the good. And people are cognizant of that and looking to see, are there some, you know, things that we can learn in terms of our normal life from it.
Mike and Nicola, can I just ask, what are we waiting for to kind of go back? Is it a kind of telling off of the death rate or infections?
Well, I mean, at the moment, we're still clearly, it is undoubtedly going to get worse before it gets better. In every place where there's data and certainly combining it all, it's behaving in the same way, more or less, in every setting. The numbers may be different, but the principle is the same. It gets worse over a significant period of time, and we're still definitely on the upswing. So the numbers of, I mean, of course, the numbers of infections that any country is declaring are very hard to interpret because it depends how many people you test. Many of us may have had the infection and been unaffected completely, in which case we've never been tested, so we're not in any of the statistics. So there's some idea of how many serious COVID infections there are, but no idea at all about the sum total. Of course, the death rate is kind of harder data that you can rely on more, and that always shows, like, it seems like in Italy and maybe Spain as well, it's kind of peaking, although it's clearly peaking in those two examples at pretty frightening numbers. That's really quite a lot of people. If you're pretty much 1,000 people a day, that's a lot of people. And that happens for some weeks. That adds up to quite impressive numbers, quite shocking numbers. So at what point authorities, clearly in China, they've taken a long time to relax. They've really wanted to see very little in terms of, you know, they've long since closed all their those emergency extra hospitals and must have seen a dramatic decline in hospital admissions altogether before they were even contemplated relaxing the restrictions. So whatever, I mean, clearly day by day, the government doesn't know what is no more likely to know tomorrow when those things are going to be relaxed than they do today. But that's going to be late April, I suppose, looking at the data from other places before it's clear that you've at least are past the worst of it. And then how long down the tail you wait is the hard question.
The other thing
sorry.
So I was just going to say, because am I right, in China it started in January and they're only lifting restrictions now, so it's like about a 4-month period.
Yeah, it probably started in December in China because they suppressed it initially. So the actual epidemic was underway for a few weeks. It was sort of third week of January, I think, that they started initially in one place to close down the city. So it was approximately 3 months.
The other thing though is that the numbers you see today reflect people who were infected maybe 2 weeks ago or maybe more, because actually we know with infection that people can be, you know, affected for a few days, but then they can get the really serious bit after a few days, and we're seeing that more and more. So really it's going to be 2 or 3 weeks. So one of the theories is why the Jewish population seem to be so overrepresented in the people who have died from coronavirus might be because of Purim, and it might be because of the intergenerational mingling that goes on in communities like ours. So at Kiddush, you'll see, you know, people from all generations all together in close contact. But the effects of lockdown, we've only been in it, we haven't even been in it long enough to know what's going to happen. Really, we need about 2 or 3 more weeks to see what the effect is, because we're still seeing the people who were infected well before that. And that's what that surge is. But then again, going back to what's going to happen. So people are talking about the second peak. So when you come out of lockdown, you know, what's going to happen then? So yeah, I think that's the thing. So you want to see the peak come down. So those curves that are going up so sharply in the rest of, you know, other places in Europe, you want to see them those numbers come right down, and then gradually let people mingle again, and probably let, you know, well, hopefully, I mean, the virus won't have gone away, but control it in that way. And the main thing is to not have the ITU departments struggling behind the virus. So again, trying to get the ITU beds, ventilators and facilities in place in time for the expected peaks, and, you know, the upward curve that we're on now is what I think the government's plan has been, Chris Whitty, and, you know, that's how they've been looking at it, from my understanding. It seems that's a sensible thing.
Can I ask? Oh, go. Just a question on. Sorry, just a question. Sorry, we've got a feedback loop here. Just a question on tracking people who obviously haven't got tested and haven't got symptoms. There was an app that was publicised earlier this week in collaboration with Guy's and St Thomas's and Wellcome Institute, King's College London, and so on. And I don't know whether that's something that's worthwhile everybody downloading and self-reporting. It just asks you whether you're feeling, how you're feeling today, and if you're not feeling okay, to describe your symptoms. I don't know whether you would recommend that we all download that, and whether that piece of information is being used.
Yeah, I mean, if you look on it, it says NIHR, which is the National Institute for Health Research. And the NIHR is a sort of centralised organisation where any sort of serious good research is coordinated through the NIHR. So it's badged by them. So that's a kind of a very it's like having the hashgacha of whoever you want to say. And I would say yes, because they'll look at the research. You know, the data is going to be difficult to interpret because most people won't get testing. We're only testing people, even if we see people who we think probably do have COVID, and these are patients with cancer, we won't test them, or we're currently not testing them unless they need to come into hospital. So, you know, in the terms of the general public, we really won't know who's had it or not. Ultimately, if an antibody test comes out, then we might find out who of us have had it. But certainly that will all be taken into account by the team at Guy's and St Thomas's running it. So I would encourage people to do it.
Because it's a sort of it's a sort of ongoing research tool rather than a clinical tool. More, it's to try and see whether, I guess, at the end of the day, when you know, in a year's time, how early were the symptoms of people who went on to develop any level of severity of the disease. So it's good to do because it contributes to knowledge about the virus. May not help you as an individual, but it's the better the data gets, the better we can maybe cope in the future, or so and so forth.
So would you kindly put that link on or send it to Ellie, Ben? That would be good, and then we'll see where it goes to the community. Thank you.
Can I ask a question?
Yep.
What can we be doing now to ease the second wave? So the government wants us to stay home as much as possible and to go out, so far as I understand it, once a day to exercise and to shop as infrequently as possible. You've mentioned Purim. We've now got Pesach coming up. How do we negotiate, you know, yet another potential spike in order to make the lives of the hospitals and the doctors easier so that you don't get yet another wave and spike in our community?
So I think second, we are now, and we will still be at Pesach in the absolute eye of the storm of the first wave. So Pesach, it will still be, may well still be getting worse by the time we get to Pesach, because of the lag time of the symptoms of the disease. So I think there's absolutely no doubt that Pesach, in terms of sort of big family groups or even relatively small Pesach, should be your household, should be at the Seder, and pretty much nobody else, which is clearly very hard on people who live on their own, and you know, in lots of situations it's completely bizarre. And as you rightly say, this is all about preventing the hospital system being totally overwhelmed, as it has been basically in all the major countries of Europe, pretty much, certainly France, Spain, Italy, and we're a little bit behind, but getting there, being overwhelmed, and the sort of scenes that you might imagine, which would be clearly very unacceptable, of people really dying in hospital car parks and hospital corridors because the hospital simply cannot take them. And that's what's happened in Italy, and that's what's happened in Spain, and we would certainly not be immune from that happening here, even given the clearly they've been pretty quick, quite impressive to get that place in East London, the Excel Centre, going as a giant intensive care unit effectively in utterly no time. If you think, you know, 10 years or something it usually takes to build a hospital, that's an impressive effort. And that's what it's about. It's about preventing the system being overwhelmed. So I think Pesach is really off, except in the most minimal circumstances within our own family groups. Second wave is a much more difficult question, because that would imply that really there's no longer where we're on the down slope of the curve, and hopefully fewer and fewer deaths and fewer acute admissions. At what point can the government, or any government actually, take their foot off the pedal against the possibility that, you know, this unseen thing is still out there, and as if everybody emerges, will it re-emerge? But I think Pesach 2020 it really has to be considered to be not a chance of normal activity during that time.
I think also the thing about preventing what any individual can do, it might be that we have an antibody test in the next few weeks, so people will know who's been infected, who's not. Like I said before, that we don't necessarily know whether that will stop you being reinfected, but there is a chance it would do, because the way viruses tend to work is they change a little bit year by year, and then suddenly they have a big change. And it's the big changes historically that have caused the influenza pandemics every 30 or so years. This is obviously a new virus. We don't know how those little changes, which allow for a sort of milder reinfection, will happen. We just don't know. But I think in terms of what you do, I suspect there'll still be vulnerable groups, and they probably should, again, we'll see what the government recommend, but it may be that they need to limit their exposure to other people, again, maybe not in such a definite way, just to allow that herd immunity in the right kind of people to develop. But yeah, I think, and again, there are other countries who are a few weeks ahead of us, so probably we'll learn from them, sadly, about what the right thing to do is or what the wrong thing to do is. But I suspect there'll be gradual re-exposure. But if people start flying around, I mean, like Mike quite rightly pointed out right at the beginning, it's not all about flying around the world, because the Spanish flu in 1918, 1718, people weren't flying around the world then, and it still managed to affect, have a global effect. But I think we need to learn lessons about how we live.
Do you think testing will be more important after we come out of the quarantine, because people can do contact tracing and try to isolate cases more?
Well, so, I mean, there obviously was a brief period where that was the approach, and that was very, very aggressively and successfully done by Singapore. Singapore has the best evidence that if you really take that to the nth degree and track people, and, with their kind of somewhat authoritarian system anyway, to really enforce people that you wanted to be isolated, to really ensure that they are doing that. When you have the sorts of numbers that are about in most of the countries in Europe and in the United States, they're far past that now, which is why you have to adopt population measures, which is what has happened. You may be right that when the numbers start to be more favorable and the system can start to take a breath a bit, that sort of approach will come back. But it was a hope, I guess, early on, like that case of the people in the skiing chalet, where I think they all managed to actually pick up the infection, although absolutely none of them were ill. At that point, they were all identified very proactively. Now, no one is really doing that, because you just have to assume that you have to have a very low threshold to assume your population are potentially infectious. All the population are potentially infectious to each other. So you have to isolate everybody. But when we improve, maybe we go back to that, because you have to let people out their isolation sooner or later. Society, I don't think, can stand being isolated for a very long time. It's absolutely unprecedented. So I guess we don't know, but then there's the small matter of the economy restarting everywhere. So that's a hard call. But yes, you may well be right, but it's not at play at the moment, because we're past that.
Just something that I thought, think about, going back to Linda, your point earlier about hospitals and infections in the future. With this, I can tell you where I work, there is no one allowed, no visitors are allowed. So we've gone from a maximum of one visitor or someone to accompany someone to an outpatient appointment, which is still just about allowed. But for inpatients, there is absolutely no visiting at all. And I can tell you from today, someone who's come in with suspected, unwell, with this virus, you have to say goodbye to your relative at the door, and then you're taken in. And that's, without the technology, it would be absolutely hideous, because people just can't see their friends, families, their relatives. But thinking now, the fact that we, 2 months ago, would have whole families sitting around the beds of people, their family, but in the bed next to them was a patient who was also ill, possibly with a compromised immune system, and we were just allowing anyone into the hospital at any time. And those sorts of measures make, now when you say, well, actually, I'm sorry, you can't have anyone, that's obviously extreme. But saying in future, maybe just one designated person, we just have to think about how we do things and not take them for granted so much anymore.
Hi, Nicola, I have a question. For someone who's been tested positive and has some mild symptoms, I think, as you said earlier, the symptoms can come and go. Do we know at which point can we consider the person is now relatively safe?
Yeah, so it's the guidance is for the person who's tested, it's 7 days from the symptoms, I think it is, but for their contacts have to self-isolate for 14 days.
Okay. Thank you.
But it's not absolutely known. That is a good question. That's one of the questions that people, if you've had it and got better, are you then for sure not carrying it to someone else? I don't think that's absolute. That's not 100% known.
Right.
But I think so. Those sort of times are probably the minimum. I suspect you still wouldn't want to be mingling too. At the moment, of course, it doesn't make any difference because, in effect, the whole population are currently being treated as if we're all infected. That's what we're doing at the moment. That's what's going on all over Europe and the US and wider than that as well.
But anyone, so like colleagues who should be at work, anyone who has been tested positive, 7 days from them, but so the hardest thing is that if someone in your household has symptoms or tested positive, you have to self-isolate. Even if they haven't been tested, you have to self-isolate for 14 days. And that's what's putting pressure on the system, because when, there hadn't been testing for staff. And even now, when there is testing, it takes a few days still to get back. And even then, it's not 100%. So if the symptoms are very suggestive, and the test comes back negative, you either need to repeat the test or assume you've got it anyway. So there's all these sort of other conundrums about things. No test is ever 100%. We know this is probably about 80%. So if you've got the disease, 80% of the time the test will say you've got it.
Can I ask if there's a question which you think we should have asked?
Not really. I think these are the questions that are being asked that around the medical establishment, and and we had a very interesting thing at Imperial of, looking from, I'm a pediatrician, we had a sort of webinar with a Chinese pediatrician from Wuhan who went through what their experience had been, and I think we are all dealing with the same thing, and I think the sorts of questions that we're all asking, and what happens afterwards, in a way, is we've kind of got into the position that we're at, and there's no doubt that that's going to roll for a while, and then I guess life is going to have to re-emerge, and the hospitals have to, it's so dominating. It's by far the greatest, because there's still patients with other problems in hospital. I feel very sorry for people having babies and that kind of thing at the moment. They're really having their obstetric care and their babies in a really unusual environment, and that clearly you can't stop them from coming to the hospital because they're all stacked up and they're coming all the time. And how we re-normalize is going to be a really big challenge. Nobody knows. There's not a person around who's had any experience, so we're going to have to learn as we go.
Nicola, what's your big question?
Well, I think it's a question that I put back to everyone else, I guess, is how would you do things differently now moving forward? So obviously that applies to the shawl, kiddishes. Do we react to this absolutely extraordinary thing to completely change our life? This thing that happens maybe it's a century only thing, hopefully, the most once a century. But do we then completely change what we do? Do we, do not have kiddishes anymore? My feeling is the answer is no. We go kind of not quite back to normal. We reevaluate what we do, and we do things differently, and we learn what we can from it. But how do we each, modify what the risks are without just living like this? Because this is obviously, it's a reaction to very, very abnormal things. So I think thinking about what are the reasonable things to do going forward once all this is over.
I just think that the nature of human nature is to go back to living exactly as they did before. And the question is, what do we do to draw boundaries around that? Because that's the most difficult. The nature of human nature, human behavior, and how it affects scientific results.
But in a way, the way this has emerged in China, in probably almost certainly in the way that where the population interacts with animals in a particular way that's not at all typical of most of the rest of us. I think every student of medicine and epidemiology has been learning that a great risk to mankind was this type of thing, and it was always a question of if rather than it was a question of when rather than if, that we, and especially in the globalized way that we've increasingly gone down, it's impossible to imagine that it wasn't going to happen. So it's you know, we've sort of drawn the short straw of living through it, but all of us have been being taught we're overdue a pandemic, it's surely coming, and here we are.
That's true. I remember in medical school in the 1990s, I remember a lecture where he said, you know, it should be every 30 or 40 years. We all thought it would be an influenza pandemic. Clearly it's something completely different, but just that sort of, I guess it's quite humbling to think however sophisticated our lives and world is, we can be brought down by this tiny little thing that we can't even see.
But wasn't SARS an example of a pandemic?
SARS was very much more self-contained. SARS had a very interesting characteristic, and that is that you weren't very infectious until very far down the disease pathway. Particularly, even you had a fever before you were infectious to others. So the practice of, you know, you will have seen that in airports of checking everybody's temperatures before they go through, has extremely low chance of making any significant difference to this illness now. Clearly, if people are actively ill with a temperature, they probably shouldn't be, they should never have been traveling anyway and sitting on a plane in close proximity to lots of people. But SARS had that sort of, as an infection, it had that Achilles heel in that it wasn't infectious until late in the disease. This is thought to be infectious very early, long before you know you've got it. That is a big problem.
Right. Can I ask you another question? Can I go back to testing? Because I'm living with somebody who's on the front line and going into the virus wards. I'm actually not living with him because I came down to the New Forest a few weeks ago, but he was going to come down, Brian it is obviously, for the weekend. And I was very hesitant about it, and we had a discussion. And I just felt that until he could get tested, I wouldn't be relaxed about us being together. Now, the answer that, or part of the answer he gave me, if I understood it, was that if he was tested and it was negative, it doesn't mean he couldn't get the virus the next day. So, or it could be a false negative, as we've been told. So what is our situation? I don't want to spend Seder night on my own in the New Forest, and he certainly doesn't want to spend Seder night on his own in London. Can you give us any guidance?
So, I mean, I guess we're all divided now into what are called households. So people who are in the same household are able to be together and are considered like one unit. So, I mean, if you've been in contact, you know, living together in the last 2 weeks, you know, who knows what either of you are carrying and pass to each other anyway. And then people are coming in and out. So Brian will have been on the wards and who knows what he's been exposed to. So I think you just have to take make a judgment call as to what's more important. If you haven't got any significant health problems and, you know, not talking about you obviously, but people who are over a certain age.
Well, I am. I mean, I'm just at that vulnerable age. That's the truth of it. So that's even more a cause of my anxiety.
Tough question. I don't think there's an answer to that. And I think the healthcare, you know, the maintenance of a healthcare workforce in the setting of the kind of question you're asking has been a major challenge. You know, who's going to be at work tomorrow is not as predictable as we've been used to, and that is a very serious challenge. In your individual, you know, I think what Brian has said hits the nail on the head. If he's how many samples is he going to do in order to absolutely know that he's no threat? Well,
Yeah.
there's no, he couldn't, there's no way for him to say he's no threat at all.
The only thing he could do would be to have a couple of negative swabs and then self-isolate for 2 weeks before coming down, but or just self-isolate for 2 weeks, but that's not going to happen. So this idea of households being on their own, you know, like people who are going out to work still on a daily basis and coming back to their household, you know, you are, I suppose, you don't know what you're bringing back in to your household. So I think you just have to make your own judgment call as to that. Obviously, Brian will have been in hospital and potentially exposed to people with it.
Yeah, he would have been.
Well, chances are he has been exposed to it. He must have been.
Definitely. I know he was there all last week, and that's what's raised this issue.
Yeah.
So I want someone to lead me by the hand and say, do this, do this, do this. It's, you know, I'm back to making my own decision again, which is pretty horrendous, really.
I think
responsibility.
Probably if you wanted to stick to the letter of the law, the government's guidelines would be you'd have to be separate because you're not one household at the moment.
Yeah, no, we're not. No.
But then they do give this caveat of more than 2 people. So you could say, you know, you wouldn't be going against their guidelines because it's more than 2 people from, if you call yourself different households, but in terms of your own risk, you definitely would be increasing the risk of getting it, having contact with him if he's going in and out of the wards.
Yeah.
I've got a question. Hi, I've got a question. When you come,
this will be the last question of the session. Thank you so much, everybody.
If you go out shopping for food or whatever, and you come back with packages, is it necessary to disinfect, to wash them down, all that sort of thing? Because I've heard that people do that. I'm not sure how effective or necessary that is.
I think the pragmatic answer to that, again, that's come up. And what about the newspaper delivery or the letters and so forth, is if you've been shopping and you've handled your shopping, obviously, is that you clean your hands thoroughly afterwards. And I think probably not to be spraying or doing whatever you are to everything that enters your house.
There is that it's thought that the virus can live for up to 7 hours on things. So if you wanted to be absolutely sure, you could leave your shopping outside somewhere for 7 hours and then bring it in. But again, there's no data to show that that's of any effect, but that's what people think, that it's up to 7 hours.
But I think if you have the shopping and then make sure you clean your hands thoroughly before you touch anything else, is as good as it can get, because you could really drive yourself crazy if you take that kind of thought to the nth degree.
I know someone who does.
Thanks so much, everybody, and special thanks to our doctors, Dr. Mike and Dr. Nicola. This has been another outstanding session. Look at the round of applause.
Thank you.
And thank you to the Shawl for putting on all these contacts. They're not as good as proper contacts, but they're good. Everybody appreciates it, I'm sure.
Absolutely.
And just our prayers and blessings to you both, Nicola and Mike, to stay safe in your profession, and stay well and stay safe.
And to everyone, thank you.
Thank you. And this is a really popular series, so we'll run another one in this series next week. That'll be the next session. We're moving on now to the 8 o'clock Zoom, which is some learning